Hey, good morning, everybody. Welcome to UAB Pathology Grand Rounds. Before we get started today, I did want to send out a few reminders, and I'll have Laura send out an email as well. We're still looking for a few faculty and trainees who are willing to do the data blitz in the coming months. That was on the calendar for May 6th and May 13th. So if you were thinking about it, please submit your name to either Laura or I. With that being said, we're also getting ready to meet as a committee and start going over what speakers we'll be having for the fall. I still do not have word of if we'll be able to have any in-person meetings. So keep that in mind when suggesting external speakers. But if you feel any topic has been underrepresented in grand rounds, please submit your names to Laura, me, or anybody else on the committee. So with that being said, today it's my pleasure to introduce our very own Dr. Dhall. He is currently the Benjamin Russell Endowed Chair in Pediatric Hematology Oncology, as well as being the head of the UAB Division of Pediatric Hematology, Oncology, and Blood and Marrow Transplantation. He initially completed his training in Mumbai before coming to the States in the late 90s, where he completed both a residency and a fellowship in New York. He then briefly started his faculty career on the East Coast in Philly at Drexel University before heading west, where he completed an additional fellowship at LA at the UC Southern California School. He then rose through the ranks in LA, becoming associate professor before we were fortunate enough to recruit him just a little bit ago in 2019, where he, as I said, is now the endowed chair in pediatric hem-onc. Looking over his impressive CV, a number of things stood out, but the one that struck me as most impressive is his ambitious role in running and chairing clinical trials, of which I think we're going to hear about one today, that Head Start, which is active and is currently recruiting across 56 centers in the US, Canada, and New Zealand. With both his impressive clinical trials, as well as other contributions to grants from the NIH, DOD, a number of cancer foundations, he's contributed in nearly 100 refereed journal articles, reviews, and commentaries. His major research area is in clinical research of the central nervous system germ cell tumors and infant medulloblastoma, and designing these large clinical trials. So today, please join me in welcoming Dr. Dhall as he tells us about improving outcomes in infants and young children with medulloblastoma, the Head Start experience, how it started, and how it's going. Thank you, Dr. Dhall.
Thank you very much, Adam, for the kind introduction. And talking about underrepresented topics, this is definitely going to be one that you won't be hearing very frequently. So, hold on. Okay, I don't have any disclosures. So basically, I thought I would just talk a little bit about on the background of medulloblastoma, give some historical background on infant medulloblastoma and what kind of survivals and treatments we have, and then talk about outcomes on the Head Start clinical trials, a series of them, 1, 2, and 3. And then we can go into the molecular landscape and how this has changed the field of medullos, and then talk about the ongoing Head Start 4 clinical trials and where do we go from there. So this might come as a surprise to some of you, at least, that if you look at children between 0 to 14 years of age, the brain tumors are the most common cause of cancer. So they surpassed leukemia in the last CBTRUS report. And not only are they the most common cancer, but they're also the most common cause of mortality from cancer in children between 0 to 14 years of age. And the incidence goes down as we go to the AYA patients, which is adolescent and young adults, or even in adults. When we look at what type of tumors children get, if you look at it, mostly in adults with brain tumors, predominantly you see high-grade gliomas, GBMs, anaplastic astros. But in children, we have a plethora of different types of tumors that we see. The most common ones are, again, astrocytomas or gliomas, and luckily for us, more low-grade gliomas than high-grade gliomas. But when you look at embryonal tumors, they make a huge chunk. That's about 13.8%. And out of those, medullo is the most common one, which was 64% of all embryonal tumors. When you look at patients who are between 15 to 19 years of age, this incidence definitely goes down to about 3.6%. And again, in this age group, you have a lot of pituitary tumors as well as gliomas account for the most of them. Now, how do these patients present? It all depends on the location. Now, typically, we would talk about different locations in the brain, but the way medullos present, they usually occur in the cerebellum, and they are mostly in the midline, and they start off in the vermis or the roof of the fourth ventricle. And what happens is they block the fourth ventricle, and they present with the signs and symptoms of increased raised or increased intracranial pressure. Or you could have some cerebellar signs such as ataxia, dysmetria, and so on. If these tumors spread, they tend to spread to the other parts of the CNS, which includes the brain and the spinal cord. So if you had disease in the cerebral hemispheres, you could see seizures, hemiparesis, and so on. If you had disease in the suprasellar region, again, we have the pituitary hypothalamus here, and then you have optic chiasm. So you would have endocrinopathies, visual field deficits. If you see the brainstem, you can see a lot of cranial nerve signs. And if they tend to spread to the spinal cord with drop metastases, then the most worrisome of that is the cord compression with back pain, weakness, sensory dysfunction, and so on. So this is just a very simplified breakdown of brain tumors. When you think about brain tumors, you think about one way to think about is the location, as I mentioned, supratentorial, infratentorial. The other way to think about is the cell of origin. So a lot of times, the glial tumors, examples are astros, oligos, ependymomas. Some of the neuronal tumors, as we're going to talk about, are medullos, supratentorial PNETs, pineoblastoma, ATRT, and so on. Germ cells shouldn't be there, but they do because of the aberrant migration of these primordial germ cells. You can see them in the midline structures in the suprasellar region, the pineal region. If they arise from the choroid plexus, you can have a papilloma, carcinoma, and so on. And the craniopharyngiomas from the Rathke's cleft remnants. So the classification of these embryonal tumors has changed over the years, and I'm preaching to the choir here. I should not be, showing this slide to you guys, but this has changed, at least in pediatric brain tumors, with the additions. So the WHO first edition in 1979 was mainly on the histopathological classification. As the field evolved in the second edition, they added some IHC and grading. In 2000, the WHO third edition, there were some additional IHC and genetics, and some additional diagnoses were added. So for example, on the 2000 edition, the desmoplastic medulloblastoma was described as a separate entity for the first time. And it was also, and this was basically based on, again, IHC with the reticulin stain, with YAP1, GAP1. And then you have atypical teratoid rhabdoid tumor, or the ATRTs, with the INI gene mutation and an IHC stain for INI1. And then in the fourth edition in 2007, again, there was some additional IHC and genetics. So now in this time, the desmoplastic nodular medullo was further classified into medulloblastoma with extensive nodularity. Now, these patients have a really high, survival, even as compared to the desmoplastic tumors. And you had some other entities like medulloepithelioma, ependymoblastoma, and so on. And then finally, in 2016, the molecular classification, there was an explosion of, data in this, in gene expression profiling and methylation of these medulloblastomas. So now since 2016, medullo is actually in WHO, it's a molecular disease. And no matter where you are in the world, people try to now subtype these. So now it's medullo-Wnt activated, sonic hedgehog activated, T53 mutated, sonic hedgehog activated, and P53 wild type, and then non-Wnt, non-sonic hedgehog medulloblastomas, and so on. The embryonal tumors or ETMRs with C19MC alterations, they were added, and so on. So I think we'll talk more about this molecular classification as we go on, but this is how at least this has evolved in the last couple of decades. Now, again, I think on the upper left is just H&E showing a classical medulloblastoma with small round blue cells. On the upper right is the desmoplastic nodular medulloblastoma, or medulla with extensive nodularity. Now here inside the nodules, you have more mature looking areas, and the internodular areas, you have more primitive ones. And these tumors tend to do very well. And the lower left is the anaplastic medulloblastoma. So you see a lot of different shapes and sizes of these cells, mitotically very active. And the lower right is a pure large cell medulloblastoma. Is usually rare, and there's the large cell component occurs in along with the anaplastic, and they end up calling them anaplastic large cells. So how do they look in radiology? If you look in MRI, you would see that these are usually, again, as I mentioned, they are in the fourth ventricle. They usually fill the fourth ventricle. This is the cystic and the solid component. This is a T2. On the T2 weighted images, they are really dark, just tells you that these are really hypercellular tumors. And this is on the lower left is the post-contrast enhancing image. These are heterogeneously contrast enhancing. And then this image shows how these are the drop metastases, this white stuff along the surface of the spine, what we like to call as sugar coating. So this is how the typically medullos like to spread. Now, when I was at CHLA, this is the first paper that came out from our group showing that if you do the MR spectroscopy, now what MR spectroscopy does, this is just extra 5 minutes on the MRI machine, and the machine can actually try to calculate the absolute concentrations of certain chemicals within this tumor. And these are mostly choline, creatine, NAA, and then this is lipids and lactates. And this one, it tells you this is the tumor signature, and it's not a demyelinating lesion and so on. But when you do the spectroscopy for this, and the choline is in the cell membrane, so the choline creatine ratio, the more malignant the tumor is, the choline creatine separation is larger. So obviously this is a malignant tumor, so you see a high choline, high creatine. But what we showed that you see a taurine, this is another amino acid, which is, if that is elevated on spectroscopy, it's a medullo. And so you could separate medullos from ependymomas and high-grade gliomas if you could show that the tumor had taurine. So how do we risk stratify these patients? So one way to look at whether the patient is low risk versus high risk is to see if they have disseminated disease. And how we say it's this, so M0 is localized disease present in the primary site. M+, we call it M+ if it's disseminated disease. And then the different degrees of M+ is M1 is just CSF positivity. M2 is when you see distant brain mets. M3 is distant spine mets, and then M4 extremely rare with extra CNS disease. Now, if the patient is less than 3 years old, they are slightly higher. They are considered high risk because you can't use radiation therapy, which is one of the most effective treatments that we have for medullos. And then the extent of resection. So if you have less than gross total resection, which is R1, that's going to be, I'll be using these R1 versus R0, then that makes a patient high risk. And as I mentioned, desmoplastic nodular, as we were one of the first groups to show that these patients tend to do really well. And then we'll talk more about this compared to if it's a classical or anaplastic medullos. And now there are more data coming in, which I'll be showing as well with the molecular subgroups. So the Wnt and the sonic hedgehogs do significantly better than group 3 or group 4 medulloblastomas, but we haven't. Head Start is one of the first trials to incorporate this, and we'll be talking about this as well. So there are some of the unique challenges when you're trying to treat infants. So, and these are really young kids. The tumors are uniformly malignant. They are very large at presentation because the anterior fontanelle is open. The head circumference keeps on expanding as the tumor grows. And by the time we find out it goes above 2 standard deviations, the tumors are typically very large. There's a high incidence of leptomeningeal spread in these patients, and they are very vascular and hard to resect. So one of the other biggest challenges we face when we're treating these infants with malignant tumors is, as I mentioned, radiation therapy to the whole brain and spine is standard of care for older children with medullos. But if you were to give whole brain radiation to an infant and a young child, the biggest thing we fear is the effect on long-term cognition of these kids. So, we want these kids to grow up as normal functioning adults, and that's really challenging. So this is just one paper showing, and as the age of the child at the time of radiation goes down, the blue line is 12 years, this red line is 5 years. And so this is how the IQ scores go down as the time passes after radiation therapy. And above 90 is average range. And this, as you can see, this curve hasn't plateaued. So that's one of the biggest challenges we have, is to try and so not just the effect on neurocognition, neurocognitive function, but these kids also grow up to have social adjustment problems. Their hearing, speech, and language is affected, and they can have impaired physical growth because of the radiation to the whole spine and radiation to the hypothalamus and the pituitary gland. So how did we treat infants in the past, and how did they do? So this is, there was one paper looking at what were the survivals in the 70s and the 80s, and you can see all the way up to 1985, the event-free survival for these patients, overall survival was about 13% at that time. And on the US side, it was about 18% from 68 to 79. This is another paper looking at survival of these infants all the way up to 2006. So when they looked at 1973 to 2006, this green line is medulloblastomas, and you can see that this is the overall survival is still in the 30s range, around 30 to 35% for these patients. So not so good. And this is compared to about 75% in older children when you use radiation upfront. So this was one of the studies that was conducted through Children's Oncology Group. This is our national cooperative group. This was a randomized trial between 2 chemotherapy regimens. Now, again, I highlighted this. This is conventional chemotherapy, not high-dose chemotherapy, and no radiation. So just using conventional chemotherapy, and then maybe focal radiation if the patient had residual tumor after surgery. And you can see the survival with this conventional chemotherapy for these 2 regimens. One was about mid-20s, and the other one was like 35 to 40% event-free survival. This was another study. Now, this study, what they did, they took conventional chemotherapy that we used in the previous one, and they added focal radiation for all patients. And so again, this was local, conventional dose chemotherapy with focal radiation. They thought this is the least toxic therapy they can give these infants. And with this, you can see here that the event-free survival, event-free survival is about 45%, 46, 47% for these infants. When they looked at desmoplasia versus non-desmoplasia, the desmoplastic infants, the infants with desmoplasia, their event-free survival was about, again, 50 to 53%. So somewhere around 50 to 55. So, because of these really low survivals in children using conventional dose chemotherapy and not being able to use radiation therapy, the Head Start therapy was conceived by my mentor, Jonathan Finley, when he was at Sloan Kettering in 1991. And so the Head Start 1 protocol ran from 91 to 97, Head Start 2 from 97 to 2003. And I was a fellow at NYU at that time, and I enrolled patients on this Head Start 2. And then the Head Start 3 from 2003 to 2009, and I was the vice chair for this protocol, and we ran this from Los Angeles. And for all these Head Start protocols, at that point, we had about 40 institutions across multiple continents who participated patients. So the treatment strategy was simple. So as I mentioned, conventional dose chemotherapy is not good enough. You don't have great survivals. So the whole idea was to deliver highly intensive chemotherapy. Now, why does the conventional chemotherapy doesn't work? In brain tumors, it works, but the biggest limitation is the blood-brain barrier. So at the doses that we give the conventional chemo, just very small amounts of these drugs cross the blood-brain barrier and enter into the tumor. And so the idea was, if we gave highly intensive chemotherapy, including thiotepa, which is a very lipophilic drug and does not know the blood-brain barrier, crosses right through it, and we might be able to increase survival. And all this therapy we give over a period of 6 months, and with the hope that we would either avoid radiation therapy completely or be able to reduce the dose of radiation therapy that we would have otherwise given if we didn't use high-dose chemotherapy. So that's the whole idea behind Head Start. So this is just, again, we focus on the principles, not into each thing. So the principle is that after initial safe maximal surgery, the patients get on Head Start 1 and 2, 5 cycles of induction chemotherapy. then they have a second look surgery. So the whole idea is before they go into transplant, they have to be in minimal disease. So we try another surgery if we saw something that was residual. Then the patient would get a single transplant with thiotepa, etoposide, carboplatin, with autologous hematopoietic stem cell rescue using their own stem cells, because this is a myeloablative dose, destroys the bone marrow. So we take the patient's own stem cells, collect them, freeze them. Then after giving this chemo, we thaw them and just transfuse it back. They have a homing device. They go back to the marrow, start dividing, and the patient recovers their blood counts about day 21. And then they got radiation only if they had residual disease. That's all. So the difference between Head Start 1 and Head Start 2, so on Head Start 1, it was realized that the patients with disseminated disease were not doing really well. So on Head Start 2, every patient who had disseminated disease received high-dose methotrexate along with all the other medications that we gave in Head Start 1 and 2. So for localized disease patients, there was no difference between Head Start 1 and Head Start 2. They all got the same therapy, but the disseminated disease patients or the high-risk patients, they got high-dose methotrexate along with the other one. So that's the only difference. So when we looked at the localized M0 or localized medulloblastoma on Head Start 1 and 2, the event-free survival was 50% and overall survival was 75% at 5 years. When we looked at different histologies, now when the Head Start, these trials were conceived, we did not have desmoplastic medullo had not been well described. So this is after the fact, we collected all the tissue samples from the sites and did a central review at CHLA with Floyd Gillis. And so when you looked at desmoplastic infants, the event-free survival was 67% and overall survival was 78% for these kids. For classical medullos, it's 42% and 75%. So good news for the desmoplastic medullo patients. Now, when we decided to look at by protocol, because when initially people were not used to using Head Start 1 or high-dose chemotherapy in brain tumor patients, and there was a lot of mortality rate was very high in these patients. So they were losing patients from toxicity or toxic deaths. So as people got more comfortable with using this really intensive chemotherapy, the survivals got better. So that's the point of this slide. Again, this is a learning curve by the clinicians on giving this therapy. On Head Start 1, it was 42%, and Head Start 2 was 67% event-free survival. That means they never had a recurrence with this therapy. And this was M0 or localized disease. Even for disseminated medullo patients on Head Start 2, the EFS and OS was around 50%. Now, this is one of the highest survivals for disseminated grade 4, WHO grade 4 tumor in an infant without the radiation therapy. So this number was pretty good, still is. So then on Head Start 3, what we did is, so as I mentioned, every patient on Head Start 2 got high-dose methotrexate. So that is pretty toxic. You have a lot of mucositis, you have hearing loss with cisplatin. So we substituted 2 cycles with slightly less intensive cycles here. So cycles 1, 3, and 5 remain the same as the previous Head Start, and cycle 2 and 4 were supposed to be slightly less intense, and the rest of the treatment schema remained the same. So this is what we did for Head Start 3 study. Again, we did not have, at that point, we didn't have even desmoplastics are not that well defined in 2003. So the primary aim of this study was 2-year event-free survival and overall survival for children with medulloblastoma, standard risk and high risk. So that was the primary aim of the study. So these were the patient characteristics. Now, the only thing I want to point out, you don't have to focus on the entire table, is that on our study, we had about 92 infants and young children with medullos who were enrolled on the study, which is pretty strong in 6 years in the country, considering how rare this is. But we had 57% of almost 60% of our patients had disseminated disease. So what it told us that the centers were probably, there was an enrollment bias here, and they were really using this therapy for the worst or really high risk patients, much more so than the localized patients. But regardless, that was the fact. When we looked at nodular desmoplastic, they were about 29% or 30%. That's pretty similar to other clinical trials. So for example, on 9921, only 30% had disseminated disease. We had 60. On 99703, another national study, 23% had M+ disease or disseminated, and we had 60. So that's the only take-home point. So here, the event-free survival and overall survival for all patients, including localized and disseminated, was 46% and 62%. So when we looked at, obviously, this is very logical. When you look at M0 or localized versus disseminated, for localized disease, our event-free survival was 60% and overall survival was close to 80%. Disseminated disease, slightly worse than Head Start 2 because we reduced the intensity, so this wasn't surprising, 35 and 52. When we looked at histology, and this green line is the nodular desmoplastic infants, and here you can see the event-free survival and overall survival is 90%. That's very, this is one of the best survival that we have seen in infant studies. The classic and desmoplastic patients don't do really that well. It's about 30 to 40% for classic anaplastic, and overall survival for them is around 50%. When we looked at just localized disease patients, again, nodular desmoplastic patients had 93% event-free survival and overall survival, and one of these was toxic deaths. That patient did not have disease when they died. And so the classic desmoplastic is, again, 40 to 50% event-free and about 65% overall survival for localized disease by histology. Then we looked at, disseminated disease by histology. And again, I think the nodular desmoplastic infants, event-free survival and overall survival of 82%. So for disseminated disease and with infants without radiation, this is great. These are great numbers. Unfortunately, the classic anaplastic, they have a different biology and they didn't do as well. So we wanted to see for the next study for Head Start 4, is there anything else we could do to de-escalate treatment? And so I decided to look at how did the patients do if they had a complete response after induction chemotherapy versus less than complete response. And these are the numbers. So if a patient has a complete response at the end of induction, regardless of whether they are localized or disseminated, their event-free survival at 5 years was 66%, and overall survival was close to 90%. This is all histologies, all stages. So this was very reassuring, and we decided to use this when we designed the Head Start 4 study, and we'll talk about this. So one of the biggest reasons why we even doing the Head Start studies is to avoid radiation therapy. So when we looked at what was the radiation-free, event-free survival, so what that means is how many survivors of this disease are surviving without the need for radiation therapy. That's what it is. And so for nodular desmoplastic infants, almost 80% they are surviving without radiation therapy. But for classic and anaplastic, non-desmoplastic, it's only about 22, 23%. So there is a huge difference in biology. It's very hard to avoid radiation in anaplastic classic, but the nodular desmoplastic, we can absolutely avoid radiation therapy. So when we looked at the multivariate analysis of event-free survival and overall survival, again, M stage and the histology were the only significant predictors of outcome in this cohort. So another big piece is the neuropsychological functioning of these patients. So again, as I mentioned, the whole reason to avoid radiation is so that to preserve their neurocognitive function. So when we looked at our survivors and what were their neurocognitive function, you can see, so the full scale IQ, so between 90 to 110 is the normal range, and less than 90 is low normal range. So full scale IQ was 95. So these patients are functioning in the normal range. The processing speed is very close to normal. So it's a little bit below normal range, 89. And the adaptive behavior is, and memory and stuff, this is about 85. So that's low normal range. So to conclude for this study, the nodular desmoplastic patients had significantly better survival compared to classical anaplastic medulloblastoma, with about 80% of these nodular desmoplastic surviving without any radiation therapy. The patients with localized disease had great survival. The patients who had a complete response after induction had a wonderful survival. And the patients who were surviving, the IQ and the memory scores were within the average range, and the processing speed and adaptive functioning was low average. So I think these were the conclusions for this study. So while we were doing this study, I think there was an explosion, as I mentioned, of data on the molecular subtypes of medulloblastomas. So the first, the hints about the molecular subtypes came from these two syndromes. So one is the Gorlin syndrome. This is an autosomal dominant condition. In this condition, you have germline mutations in a sonic hedgehog receptor gene called patch. The patients, 3 to 5% of these patients develop medulloblastomas, and almost all of them are desmoplastic medulloblastomas. Then there's another one called Turcot syndrome. Now, in this syndrome, the patients have mutations in the APC gene. Now, this plays a role in the Wnt pathway. And here, the patients have a 92-fold higher risk of developing medulloblastoma. So this gave a hint to the researchers that there are probably some subtypes with sonic hedgehog pathway and the Wnt pathway that exist between these medullos that look the same under the microscope. And so this is just a cartoon showing these two pathways. So on the left here is the sonic hedgehog pathways. Now the membrane receptors for the sonic hedgehog pathway are the smoothened and patch, and the ligand is sonic hedgehog. So in the inactive form, patch has an inhibitory influence on smoothened. When the sonic hedgehog binds to patch, this inhibitory influence is released. Smoothened actually then translocates to the primary cilium, where it ends up activating GLI1 and GLI2 by activation of KIF7. These GLI2, GLI3 separate from SUFU, move to the nucleus, and they activate transcription. Now, for the Wnt pathway, the membrane receptor is called frizzled, and the ligand is Wnt. So when this is inactive, the beta-catenin exists as a protein complex in the cytoplasm. But once this pathway is activated, when Wnt binds to frizzled, this ends up in disruption of this protein complex. The beta-catenin separates from here, translocates to the nucleus, and activates transcription. And about 40% of the medullos are sonic hedgehog or Wnt activated. And this is the first paper in 2002, came from Scott Pomeroy's group in Boston, looking at the gene expression profile in medulloblastomas. So when they looked at the gene expression profile of different pediatric brain tumors. On the left is the medulloblastoma. You have a malignant glioma, rhabdoid tumors, PNETs. You can see that the gene expression profile was very different of these medullos compared to the other ones. So you can really pick them up, because sometimes, as you all know better than I do, that even in older patients, sometimes you get confused between small cell GBM versus a PNET and so on. Not in cerebellum, but more so between PNET and a high-grade glioma. So then they decided to look at just the medulloblastoma patients. So here you can see, again, even between the medullo patients, there is a clear contrast in the gene expression profile of classic medulloblastoma patients versus desmoplastic medullo patients. And the genes that are upregulated in these are, again, in the sonic hedgehog ones, these are, the bright red here, are the ones that belong to the sonic hedgehog pathway, such as GLI, patch, NMYC, and so on. So after this paper in 2006, this came out from Rich Gilbertson's group from St. Jude, where they showed that so when you look at the molecular classification, it's not just the sonic hedgehog and the Wnt pathway, but there are more subtypes. And in their hands, they could find 5 subtypes where they separated them by gene expression profile. Now here, the B is right here. This is mostly older patients. They have monosomy 6. Histology is classical medulloblastoma, and they have Wnt pathway activation. The subgroup D here is mostly infants. This is the age group. They are mostly nodular desmoplastic, and these are the ones that are activated, the sonic hedgehog activated tumors. So you have a Wnt pathway, which is group B, sonic hedgehog group D, and 3 other subtypes that had some overlap between them. So then at the same time, another group came out from Germany, from the Heidelberg group with Marcel Kuhl and Stefan Pfister. And they also were able to find 5 molecular subgroups. Again, subgroup A, Wnt and Wnt pathway signaling was activated, and subgroup B was sonic hedgehog activated. And again, subgroup C, D, and E with some overlap between them and not real clear distinction. So in their hands, it was 5 subgroups. Then came this seminal paper from Michael Taylor's group in Sick Kids in Toronto, and they took samples that they had in Toronto and combined them with samples from St. Jude, and then validated this with the Heidelberg group. And they showed that they in their hands, they divided this into four subgroups: the Wnt subgroup, sonic hedgehog, group C, and group D. And this is just a principal component analysis showing that there's a clear separation between Wnt, sonic hedgehog, and there's a lot of overlap, just like the previous ones, between group C and group D. So when you look at what types of tumors occur here, so the sonic hedgehog tumors, they have a bimodal peak. So they are very common in infants. 65% of the infant tumors are sonic hedgehog activated, and then they have adults. So if any of us on this call had a medulloblastoma, 70% chance that this is a desmoplastic tumor and or a sonic hedgehog activated tumor. Then in children 4 to 15, as you can see, predominantly it's group C and group D. And Wnt pathway tumors are much more common in children. They're not so common in adults or in the younger group. So they also added some clinical features in this paper, which were lacking in the previous ones. As you can see, Wnt pathway tumors, almost all are M0, predominantly sonic hedgehog or localized disease. When it comes to group C, a lot of disseminated ones, obviously small numbers, and then group D have a smattering of both. And when they looked at survival, this is Wnt survival, this is top blue. This is almost 100% survival with, this is regardless of how they were treated. The red line here is the sonic hedgehog pathway tumors, and their survival is about 80%. And group C, they had no survivors. So really bad prognosis. Group 4 was somewhere in the middle. So because of these different subgroups from different groups, they had a consensus conference, and they came out with this consensus paper where all the groups, the St. Jude, Boston, Sick Kids, and Heidelberg, they decided on 4 molecular subgroups of medulloblastoma. That's what made it now into the WHO book in 2016. So it's Wnt, sonic hedgehog, group 3, and group 4. And again, very similarly, these are, Wnt pathway in children. They're rarely large cell anaplastic, rarely M+. Wnt signaling, sonic hedgehog is again in infants and adults, and so on. And they also describe some of the cytogenetic abnormalities in each subgroup. So like for example, isochrome 17q is very common in group 3 and group 4, whereas you can see the 9q minus 10q loss in sonic hedgehog and monosomy 6 in Wnt pathway tumors. So this was all this work up till now was the gene expression profiling. And so there was another, so then we started talking about the methylation profiling. There are a lot of groups that publish that if you look at the DNA methylation across this tumor, again, you could divide these tumors into the 4 subgroups, just like the gene expression profile: sonic hedgehog, Wnt, group 3, and group 4. So great. So we had gene expression profiling, we had methylation profiling. And now this just came out, 2-3 years ago, where the Sick Kids group have combined the gene expression and methylation and even further subdivided these 4 groups into multiple different groups. And now we have 12 medulloblastomas. They all look the same, small round blue cells under the microscope. There are 2 Wnt subtypes, 4 sonic hedgehogs, 3 group 3s, and 3 group 4s, and so on. So again, this is very recent. I don't know if this will be adapted, into the clinical trials and stuff, but this is where we are right now. Anyway, so then when we were designing the Head Start 4 study, we decided to look at our CHLA samples in 2000 after the Head Start 3 closed. So we had about 90 medullo samples. We did the TLDA assay and the gene expression by TLDA assay. And we were able to show that we could separate these tumors again, just like Mike's group and other groups, into sonic hedgehog, Wnt, group 3, and group 4. And we could also show that using chromosome microarray, we could pick up a lot of these cytogenetic findings, like monosomy 6 for Wnt, loss of chromosome 9 and 10 for sonic hedgehog, isochrome 17q for group 3, group 4. We went a little bit further. We also, because of the expertise we had at CHLA in MR spectroscopy, we decided to see if we could separate these groups even before they went for surgery, just looking at MR spectroscopy, if we could tell which subgroup they are. And we could show that in sonic, and indeed there is a difference. The sonic hedgehog patients, obviously everybody, all of them have a high choline and low creatine, but they have a high lipid lactate peak. Group 3 and 4 did not have a high lipid lactate peak, but they did have a high myoinositol and high taurine peak, which the sonic hedgehogs didn't have. We didn't have Wnt at that time. You don't have to go into this. And this is, since I left, they've continued this work, and they've accumulated more Wnt patients now, and they've added another amino acid called glycine. So now, so the group 3/4s have high glycine, high myoinositol, and high taurine. Sonic hedgehogs have a high lipid lactate. Wnt have neither of them are high. So this hasn't been published yet, but they're in the process of writing this paper. But this would be very cool to be able to subtype these patients even before they get operated on for surgery. It's important because if you already know this is a Wnt patient, you really don't have to be very. We know they have almost 90 to 100% survival. You can leave some tumor behind. If you don't have to be super aggressive in trying to get each and every a visible cell out. So I think that's the important part. Then we looked at CHLA, if we looked at these subgroups and infants who were treated with radiation avoiding strategies, how did each subgroup do? And if you look at it, the sonic hedgehogs, they almost have a 95% overall survival with radiation avoiding strategies. So this was reassuring. Wnt pathway tumors are not, as I mentioned, they are extremely rare in infants, so we didn't have any. But this was reassuring that the sonic hedgehogs have a great survival. So this is then what we decided to do for Head Start 4, is that, so the first one was the molecular risk stratification. So this is, we knew that in the next generation of clinical trials, we had to adapt this molecular risk stratification. We had to do the risk stratification, molecular subtyping up front. And then as I showed you that the patients who had a complete response to induction, they did really well. So then we decided to compress the induction from 5 cycles to 3 cycles. So that was the second study question. First one was to feasibility of doing molecular risk stratification. Second question in the trial is the compressed induction from 5 to 3 cycles. And the third, the primary aim is randomization between a single transplant versus 3 tandem transplants. And this is important because, the Head Start standard of care has been a single transplant, as I showed you. But the Children's Oncology group, or our national cooperative group, they like to do 3 tandem transplants, which is 1 month of inpatient treatment versus 3 months of inpatient treatment. There is a psychological cost to it, there is a social cost to it, and there is a financial cost to it. So I think it is important for me to know, is 1 cycle the same or different, more toxic, more efficacious than compared to 3 cycles? So those were the big study questions we decided to ask for Head Start 4 clinical trial. So this is the study schema. Sorry, I'll try to walk you guys through it. So at the time of surgery, as soon as we get the tumor, we try to do the molecular risk-based stratification. Now, when we started this study in 2000, and when we were designing this in 2009, 2010, none of the labs in the country had a CAP-CLIA methylation or CAP-CLIA gene expression profile. So we really could not, because we wanted to use these molecular risk stratification for clinical decision-making, we could not do that at that point. So what we decided to go is with OncoScan, which Jackie Beagle runs. We recruited Jackie Beagle to head the precision medicine at CHLA. And so we used chromosome microarray, as I showed you the different cytogenetic findings that we found, to see if we could separate them in group 3/4 or sonic hedgehog and Wnt. And then we thought that as we collect the samples on every 20 to 30 samples that we collect, we will send them to CNMC in Washington to do the nanostring or the gene expression profile, just to make sure, are we doing the right thing? So we would do it at the back end, but not for clinical decision-making at that point. And then we use the histology, YAP1, GAP1, nuclear beta-catenin, and so on to divide these into low risk versus high risk, So we don't have to go into this table. So if they were low risk medulloblastomas, which is sonic hedgehog infants and Wnt, which is going to be, we have maybe 1 Wnt out of 143 right now because they're so rare. they would get 3 cycles of chemo, and then they would, if they are CR, they would go straight to single consolidation. So we are trying to shorten for sonic hedgehog patients from 6 months to 4 months of treatment. So 3 induction cycles and 1 transplant. And for high-risk patients, also 3 cycles of chemo. And if they are a complete response of no evidence of disease, which is about 70 to 80% of patients in this group, they're going to go straight to randomization between single versus tandem consolidation. So that's the idea behind the Head Start 4. And so we would divide them into Wnt, Sonic Hedgehog, and Group 3-4. So primary aim, as I mentioned, is this randomization between single and tandem. And then these are this is the secondary aim, is from 5 cycles of chemo to 3 cycles of chemo. So we have lots of additional secondary aims, such as hearing loss, toxicity, quality of life. We're trying to look at biomarkers of radiation-free, event-free survival. We're trying to see if we can use CSF microRNA as a biomarker, and so on. So a lot of secondary aims that we hope to look. And so far, the study has been going really well. So this is cumulative open sites. We are at 57 sites right now across US, almost all of Canada, and a couple of sites in New Zealand, 1 in Australia, and so on. And so we have about 140, at the last count, we have 145 patients enrolled on the study. We need to accrue 250 patients for this entirely, and so that for us to be able to randomize 200 patients, we need 250. So we have another 100 patients to go. But the study is going well, so we hope that we should be able to do it in the next 3 to 4 years. So as I mentioned to you, when we started, we did not have the luxury of having gene expression or methylation as a CAP-CLIA test. So what we did is, so this recently we sent about 60 samples that we had assigned the risk assessment here, based on immunohistochemistry and based on OncoScan or chromosome microarray. And so this is what we had assigned. And then these were the nanostring results. And you can see there's almost 100% correlation between what we had assigned so far and what the nanostring showed us, except for 2 cases. They were indeterminate on nanostring, but we were able to. So actually, you all would be glad to know that histopathology with YAP1, GAP1, nuclear beta-catenin, it was able to call these into different subgroups 100% of the time. So that really won. There were a lot of the chromosome microarray that was indeterminate. There were a couple on nanostring, but the histopathology, we were using the IHC, the H&E IHCs, we were able to really call whether this was sonic hedgehog, Wnt, or not, or group 3, group 4. This is just, you don't have to do, this is just to show that, we just took 10 samples and did so we're collecting tumor tissue, CSF, blood on all our patients. We just, tried to do the whole exome sequencing on 10 samples. We did the methylation, and so on. So this we presented at SNO, but we hope to build on this and do it for all. Once we have all the 250 samples, Elaine Mardis now at Nationwide Children's, she is the biology chair. So she's going to be directing all the biology studies on these tumor samples. So this was just a feasibility to see that we could do this on the current Head Start samples. So moving forward, where do we go from here? So we decided to, so on the low risk arm, as I mentioned, we had only 3 cycles and 1 transplant. These were all sonic hedgehog patients. We decided to see how they're doing. And so as I mentioned, on Head Start 3, we had 90% event-free survival. So far we have about, and this is even older, again, we haven't, this DSMB has not released these data, but we have about 36 patients and we have 3 relapses so far. So we are, at least as of today, we have more patients than Head Start 3, and we are 90% event-free survival for these. So these look very encouraging for the sonic hedgehog desmoplastic patients on Head Start 4. So at the same time, so at the same time, while Head Start 3 was ongoing, and actually Head Start 4, 2 groups tried to treat nodular desmoplastic medullos with conventional dose chemotherapies. As I showed you, conventional dose chemotherapy for all medullos did not do so great. They thought that, okay, let's try this in desmoplastic nodular patients. Maybe they will do much better. So this was one study from Children's Oncology Group. They tried conventional dose chemotherapy for nodular desmoplastic. And here you can see the progression-free survival is close to 50% for these patients. So remember, it's 90% for our group on Head Start. And this was published in 2019. So this was just less than 18 months ago. So this group failed to, increase the survival for desmoplastic. Another study from St. Jude was published in 2018. And again, in the St. Jude approach, they also tried conventional dose chemotherapy. And even in their hands, nodular desmoplastic, 52% event-free survival, so compared to 90% for our group. And they had another one where they divided into, Sonic Hedgehog 1, Sonic Hedgehog 2. So the take home was that two other groups until last year, 50% progression-free survival compared to our group, which is 90%. Now, there's only one other study in the literature that was conducted by the German group, cooperative group. This is called the HIT-SKK92. And they used conventional dose chemotherapy, but intraventricular chemotherapy, methotrexate. So they gave the methotrexate into the ventricles for these patients. And using that strategy without high dose chemotherapy, conventional dose chemo plus intraventricular methotrexate, their progression-free survival was very similar to Head Start. So this was 85%. But when they looked at the IQ scores here, their IQ scores were, as compared to the control group, they took a significant hit, but they were in the low average range. So they were not that different from Head Start, slightly lower than the high dose chemo, because the intraventricular methotrexate, when you give it, it causes leukomalacia, periventricular leukomalacia, and affects neurocognition. And so that was the biggest concern with this strategy, but only other clinical trial that showed survival as close to Head Start. And their long-term IQ scores, again, were also around 85 here. So I think that's low average range using the intraventricular methotrexate. This is their not just 5 years, but 13 years neurocognition. So we put together another proposal now. The German HIT trial was led by Stefan Rutkowski in Heidelberg. So Stefan and I put together a proposal for the next study now after Head Start 4, because we've almost completed accrual for the low risk arm. And as I showed you, these are the only true strategies that have shown a promise in improving survival. So we've designed this new clinical trial where, again, focusing on the main point here, we hope to randomize patients between Head Start 4 versus the HIT regimen in Germany. And for the first time ever, I think we were going to make neuropsych evaluation as a primary objective, because we both know with both of these treatments, we can attain 90% event-free survival. So the main primary endpoint is going to be neurocognitive evaluation 2.5 years after diagnosis. So half the patients will get Head Start 4, low risk arm, and half the patients will get the HIT regimen that I showed you in the previous slide. So that's the study. And obviously, we are going to do molecular risk profiling, and including methylation profiling, because now we do have it CAP/CLIA certified in Cincinnati and NYU. And so we hope to do, we at UAB will be leading the North American component, hoping to get all these 60 institutions on board. And then the European, there'll be 19 European countries that will be participating in this clinical trial. So this is going to be a true transatlantic collaboration between SIOP Europe. SIOP is the International Society of Pediatric Oncology, including 19 countries there, and most of the North American sites here. So we'll see how that goes. We've currently applied for funding for this study and through the German Ministry of Health, and we have some funding promised through the Connect Consortium here in the US. So why is this trial important? So this trial, because when I go to the low middle income countries and give talks on these, it's great for us to have 90% event-free survival with high dose chemotherapy. But when I go outside, they just don't have the luxury of using autologous transplant for these patients, because when they have one transplant treatment center and their priority list is allogeneic transplants first, ones who have leukemias, lymphomas, and then they have neuroblastomas for the autologous, and brain tumors are the lowest on the list for them to do a clinical trial. Plus Thiotepa, which is really the hallmark of this regimen, it is extremely expensive. It's hundreds of thousands of dollars for a transplant. It is just, they can't afford it. So even if this was a negative study, meaning the neuropsych, we think that with high dose chemo, the neurocognitive function is going to be better than this intraventricular chemo. But even if it is a negative study and they are both the same, I think this would give a great treatment option to these low middle income countries to use the HIT regimen and not use the high dose chemotherapy regimen like Head Start for their patients. So I think it's very important when you look at the big picture here. And as I mentioned, funding application has been submitted, and we will be applying for funding for the biologic correlates here in the United States. With that, I think I would like to thank all the folks who have funded these studies in the past. And my mentor, as I mentioned, Dr. Jonathan Finley, who just recently retired, all the treating physicians who've believed in this philosophy, enroll patients, and most importantly, patients and their families. Thank you.
Thank you, Dr. Dhall. That was very impressive. What an amazing turnaround from where things were just 20 years ago. To see that, it's very impressive. We had one question in the chat. Dr. Alexander, would you like to unmute, or would you like me to read it? Okay. His question was, is there variance within groups on amount of necrosis?
Not that I know of. I've looked at these pathologies over the last 15 years. Each and every patient, we did not see the difference in necrosis as one of the features that could set any of these apart.
Thank you.
And then I actually had a question. I think one of the most impressive things to me about what you're accomplishing here is the breadth around the world. In bringing in some of the more subtle nuanced changes like DNA methylation, will you have the power to see, are there regional influences that affect severity of disease progression? I mean, I know pollution can affect DNA methylation, diet, race, and branching out so far, will you be able to find common denominators? Does that question make sense?
That's a very, deep question, I would say, but very hard one to look at. In this, the scope of this is very limited, because when we do the methylation, as you know, if you put in a tumor into this gene expression algorithm, it's gonna, whatever you put, it's gonna divide one into one or the other. It's gonna put into one of the other basket categories, but hopefully methylation will be different. But I don't think we're looking at, we're probably just looking at that particular signature, and trying to see if it might be because we will have the tumor. It could be something, if somebody was interested in looking at those, then absolutely we could use those tumor tissues to do those analysis, but they're not part of the primary or the secondary aims at that point. But absolutely, if there was a researcher who was interested, we would have the samples for them to look at. What we've done with Head Start, and we hope to do this one, is that we have it like for Head Start 4 right now. As I mentioned, we're collecting a bunch of tissues, and everything is banked at nationwide. And so the whole idea is that if there was a researcher at any of our Head Start institutions who wanted to look at a question, then they would submit a proposal to us, and then we have a biology committee, and we would prioritize which ones to look at. But that would absolutely be an option if someone was interested.
Okay, thank you. Are there any other questions?
Adam, this is Upender.
Yes.
Hey, Girish, outstanding talk. I learned a lot on brain tumors. So I have one philosophical question. In adult cancers, in order to develop and evolve pre-malignant to malignant disease, it takes decades. But here, brain tumors, or is it medulloblastomas or any variant, they are developing within first 8 to 10 years. The hereditary component, familial component is very small. So what do you think, why they are developing cancer even though they are so young?
Well, not even 8 to 10 years. A lot of these patients, that the youngest one that I've treated with medullos is like 3-month-old. So this is in utero. So 3-4 months old, they where I've treated, given all this therapy, high dose intensive induction. Yeah, all I would say is a lot of these pediatric ones are genetically driven. So where in the adult ones, you accumulate a lot of hits. But here, the genetics plays a lot more part in the development of these pediatric high-grade tumors than adult ones, I guess.
So the other question is in line with Adam's question, because methylation, dietary, all those influences. Do you see here in Alabama any disparity in the incidences of these medulloblastomas between African Americans and Caucasians and gender, like boys and versus girls? Do you see some?
Yeah, we haven't. So I haven't looked at here specifically in Alabama. We can definitely look at our data to see if we see any difference in. Obviously, it depends on the patient population. If you have more African American patients, or people who are living in a state as compared to other ones, you may have a higher incidence in this. But overall, when we've looked at multiple different, national clinical trials, including Head Start, we did not see difference in sex or race for these tumors. There's clearly differences in germ cell tumors that the other research interests were, but that's also more genetic, where 2/3 of them are males as compared to females and so on for each specific subtype, but not for medullos so far, Upinder.
Thank you.
Well, perfect. And that brings us to the hour. Thank you again for that very interesting talk. And remember, Dr. Dhall is now on our campus. So if he said anything that interests you, hopefully we can find new ways to collaborate. And I look forward to meeting you in person one of these days.
Absolutely. Thank you very much for the invitation.
Thank you, Dr. Dhall.
Thank you all. Bye.